not half an hour ago on the tram coming in from where I was staying. Little girl in that, my kids are a bit older now, but I think in that, is it that kind of 5, 6-year-old, 7-year-old stage where every question's a why question? You know, a little girl pipes up to her dad in the tram, "Why do schools exist, Dad?" And she didn't give him much time to answer because the purpose of the question was, she revealed the purpose of the question pretty quickly, which was, "I don't want to go today." But it's a good question, and you know, like the woman beside me on the tram said, "From the mouths of babes, hey, you know, why does it exist?" I mean, what? And it kind of prompted, of course, straight away about purpose of today, purpose of collaboration overall. I mean, we've been doing it as a species since we, you know, were on this earth. Had to collaborate from the moment emerged from the cave. You know, that's the nature of existence, and yet still really struggling with it in so many ways. So from silos to symphonies, the metaphors I think are a really good one. Wanted to just put on the table to start with in terms of the silos metaphor, a little danger of mixing metaphors, but a little bit of danger I think of throwing out the baby with the bathwater in terms of silos. What helps, I think, to kind of actually recognise a really fundamental function that silos provide, which would be pretty obvious to everyone, but particularly that they are an absolutely crucial warehouse of such a core staple commodity, grain, in our society forever and a time. And we don't ever, of course, want to lose that and lose that functionality of a silo. And of course, to dress them up literally a bit more in recent years, there's been a movement right across regional Australia. I do a lot more work these days in regional communities. This is from a tiny town in West Queensland called Fallon. But there's plenty of, in fact, it's rare to go through a lot of regional towns these days with their standout silos without some kind of art adorning them. And, you know, so silos still provide a really critical functioning role, and again I think a couple of our speakers are going to say a bit more about that. So this is not about, we all recognise the problems and the barriers that we face with a silo-based mentality, but again my experience is that most people are hankering to go well beyond any silo thinking and break out of their silos, and a lot easier said than done, of course. So the Communities for Children program started back way back in 2006 when, through the federal government, in the last year of the Howard government actually, under what we now know federally as the Department of Social Services, was at the time the Family and Community Services, FACS, federal department, that you know, was clearly identifying, as many people had been for a long time, of a clear demographic discrimination, I guess, in the likelihood of children growing up to be thriving individuals and improving their well-being, and a lot of those demographic constraints are becoming increasingly difficult to combat. So over the course of Communities for Children nationally, again, I'm kind of assuming I'm talking to an audience that's reasonably aware at least of the program, if not the finer details, but that Communities for Children now exists in over 50 sites across Australia, all with a commonality of being reasonably low socioeconomic status communities, but with a whole lot of diversity amongst those, including the 6 in South Australia. So their particular role has been to provide lots of different support for all the work that's going into improving children's development right across those areas. So that this role is particularly crucial for being a facilitating partner, and I just wanted to focus on those facilitating partners' role. That has become a role that's become particularly important in the most recent phase, I'm going back now to 2010, 2011, when the model of Communities Children went from being a lead organisation but being also a funding provider for various organisations, and also a service provider, went to being just a funding provider but a coordinator, and hence the name facilitating partner, a really fundamental one. And all those dot points are essentially the building blocks, if you like, of those facilitating partners' role. This slide, I'm told, and I have seen it, is in your program, so it really just is capturing an overview, and don't want to dwell on it for a moment, but just to, I guess, hopefully confirm what I've been saying earlier about just the extent of activity amongst the 6 sites, Communities for Children sites in South Australia. There's some pretty impressive numbers in there, but hopefully above all demonstrating a real connection in this collaboration space.
So 40% of children in sole parent households live in households below 50% of the median income. I'm not telling you anything new, but I just want to remind ourselves as we think about the kind of work that we are all trying to do in various ways. There's a context, a much bigger context within which we work that affects everything that we try to do. And we don't directly change those things. But when we've got 530,000 children in Australia in income poverty, the interesting thing to me is to look at these by age groups. So that's the highest proportion of any age group. And if you look at what's happened to 65 and over, the income poverty in that group has plummeted. And rightly so, that's a good thing. But we now have 0 to 15-year-olds as the highest proportion of our population in income poverty. And then we can also think about this in terms of consumption poverty. And that's the ability to have unmet needs, things that children ought to have that they are not able to afford to consume. 600,000 children under 15 in Australia. Again, I don't need to remind you, but for me this is always the context within which we're working, this bigger picture of trying to help children have better, decent starts in life. Those disadvantages don't sit on their own, they're multiple, they cluster together, and according to this report from the Productivity Commission, 20% of children under age 15 have 2 or more of these multiple deprivations. So, my job today, in the spirit of silos being broken down or merged and collaborating, is to tell you a little bit about a resource that we have in South Australia that is exactly built on the idea of fostering collaboration. Some of you will know about this, some of you may not. My job is to try to tell you this is a collaborative resource that we have in South Australia. Other jurisdictions do not have one of these. We have the best in the country. And so it's up to us to think creatively about how we can use such assets to foster collaboration. So this is the South Australia Early Childhood Data Project. It contains every birth cohort from 1991 going forward of South Australian children. That means there's about 350,000 children, the experience of 350,000 children born in South Australia. And then whenever children come in from interstate, they might not be born here, but they come in and they go to the hospital or something and we pick them up as well. Importantly, that's 18,000 Aboriginal and Torres Strait Islander children. So for small population groups who are often invisible in research enterprises, this gives great capacity to look more closely at the experience of Aboriginal and Torres Strait Islander children. So we've got lots and lots of records, 30 million, we just stopped counting after that. The important thing is this is a public good resource. This is not my data, this is your data. You paid for this to be collected, and it's my job to figure out how we can use it better, because it's collected in silos. That's how government and other agencies collect data. We take the silos and join them up, and that's how we're able to give some idea of the experience of different groups of children where their information is linked up across those silos. So this is one small part of building a collaborative enterprise to assist us all in the work that we're trying to perform. And I suppose that's what I really want to get across today, and I'm going to say more about it. But the context within which you work, we would like to try to think of ways, creative ways, that this resource can help you do your jobs better. And one of those ways, I think, is in terms of trying to have a better lens on evaluating what works in terms of what you do. So that's a challenge for all of us. But the first point is to make everybody aware that this resource exists in South Australia. So as I said, in the last 2 years, we've done a lot of stuff that is within government, and it's confidential within government now. There's about 35 different research briefs on lots of different things. A couple of those are public. What we do when we link up information is we can turn that activity into the experience of a child. So we can tell whether it's 10 different children or whether it's the same child 10 times. That's what's important about this ability to link data up, because the siloed systems can't do that. They can only count activity within the silo. So if you average it out over these birth cohorts that we've got over from 1991, there's about 20,000 births in South Australia every year. So by age 10, so what I want you to think about is we have each year, there's 20,000 children born, and we follow them through until they reach age 10. And then we count up the child protection experiences of that entire birth cohort. Does that make sense? So we're following them through to age 10. Out of that 20,000 births, about 4,700 children will receive a child protection notification. That's 25%, that's 1 in 4. That's the 1 in 4 number that the previous government released after the Nyland Commission. So the first thing to recognise here is notification to child protection is not rare. This is a very large problem. It's a massive problem. That's twice the prevalence of childhood asthma. So you think about the scale of that and how we're going to deal with that. That's a public health problem. So of those 4,700 children, about 19% of the total will be screened in, 10% investigated, 5% substantiated, and just under 2% will experience at least one episode of out-of-home care. So I'm a public health epidemiologist. The first thing I notice with this is, well, of the 4,700 children, 1,364 are not screened in. 1,649 are not investigated. 829 are not substantiated. That basically means the child protection system doesn't do anything. So of the 4,700 children, about 80% receive no service from child protection. That means they're just going back out into those same circumstances that generated the notifications in the first place. That is a massive opportunity for prevention. We can use that information and we can try and support those kids and those families. So these are a couple of the actual published reports. You can find this on our website if you want to go and have a look. And a lot of the numbers that I'm going to show you appear in that one on your right, the child protection in South Australia. So let's start digging into this a little bit deeper. So of these children who are known to child protection, one of the things we want to know is what's the age pattern for this? So we're interested in under age 5 because that's when kids enter school. So this is before they're entering the formal education system. So of all of the notifications, just over 50% will occur under age 5. 55% of the screenings, 64 of investigations, 60% of substantiation, 69% of out-of-home care. So if you're in the child protection business, half of it is under age 5. And that immediately has implications for who's the workforce that's there under age 5 supporting these families. In the early part of life, that's largely the health system. Then we have childcare and we have preschools. So we start to think about what are the agencies with feet on the ground that can help in this prevention effort. So the implications, especially for the health system, are important to think through, and I'll show you some of the work we've done with child and family health. So, key message to walk away with, child maltreatment is common. I did not believe this number when we first did it. I said that cannot be right. It's too big. It's not. It is correct. So 25% by age 10 in each birth cohort will have a notification, and half of that's under age 5. Let's take a look at out-of-home care. So this is out-of-home care patterns by year. Yeah, this is a terrible slide. This is where I say, I don't intend for you to read this. And that's where you rightly say, then why the hell did you put it up there? So let's just get the message. So you can see this as age down the bottom. These different coloured bars are just different birth years, birth cohorts. So here's the story. Out-of-home care for under ones hasn't changed much from 1999 to 2013, age 3, even at age 10. So the story here is the proportion of all children entering care has not substantially changed over time. Some of you will see AHW reports that says it has. That's because they can only count notifications and they can't count experience of the children. What has changed is if we look at guardianship orders for 12 months, they've gone up a little bit over time, 1999 to 2013. So they've gone up, increased over time. If we look at guardianship orders for 18, then we have massive changes from 1999 to 2013 at all ages. So the proportion of all children experience guardianship 18 orders has increased over time. The key message is children are going into care for longer periods of time, and the fastest growing segment is guardianship 18 orders at very young ages. And that probably reflects changing culture and willingness to intervene earlier to try to take kids out of very undesirable circumstances. Children who've had no contact with child protection, the great thing about a whole of population database is you get to see the children who don't hit your system. And unless you can see the ones who don't, it's very difficult to interpret only the ones that you do see. So these are the children who've never had a contact with child protection. Here, they've had at least one notification but not screened in, at least one screen in, at least one investigation, no substantiation, at least a substantiation but no out-of-home care, and one or more out-of-home care. So this, if you like, is more severe progress through the child protection system. And then what we see is this is developmental vulnerability. So for children who've never had contact in South Australia, there's 17.7% of those children are developmentally vulnerable at age 5 on one or more of the AEDC domains. You can see here, for these children who've progressed into the more serious end of the child protection system, where over 50% of those children are developmentally vulnerable at age 5. These poorer starts in life we know are very difficult to overcome, but they're evident very early. These children aren't even in school yet. The other thing to look at is this group. So this is the group that's just had one or more notification and nothing more serious. So there are some people who believe that all of these notifications are false positives. These are children who are being reported because they don't have the right piece of fruit in their lunchbox at school or something. So there will be some of those false positives, but what this shows is that on average, these children who've only ever had at least one notification and nothing more serious, they are twice the level of developmental vulnerability than the children who've never had contact. So on average, there's something going on with those kids. People are notifying, and on average, those children are not doing well. So the idea that we can dismiss these notifications as being false positives is just empirically not correct. So if we look at those young mums, there's 644 young mums with 1,180 children in the data. 67% of these mothers had their own child protection experience. And again, everyone's nodding. You know this stuff because you work on the ground. So we're looking at almost 70% of the children in out-of-home care are actually an intergenerational process through the child protection system. So that's a prevention system for child protection. In practice is not well articulated, despite the number of people saying we need one. And because I'm a public health person, you would think that I'd have all the answers, which of course I do not, because we'll need to co-design this. What does a prevention system look like for child maltreatment? We'll have to all work together to figure out what that looks like. So here's the progression through the child protection system from being notified through to out-of-home care. This will involve statutory child protection responses. Child protection system is under statutory responsibility to take care of the highest risk children. This will require broader system responses. What do we mean by broader system responses? Well, we keep saying child protection's everyone's business. Well, what is the child protection system or the potential child protection system? We started to map this out. And here, again, here's another one of these slides that you can't read, and you should say, well, stop putting them up. So we see child protection in here in the middle. And these are agencies that have a child and family focused service responsibility. So we'll see the antenatal system, here the postnatal, we can see children's centres, child wellbeing practitioners, childcare and preschool, all the way down these CAMs. Primary care, we haven't talked much about the role of general practice in primary care, and Aboriginal community controlled services. So these agencies refer into child protection, but they also have their own child and family focused service responsibilities. One of the issues is, can that role be expanded? And that's what CAFS is doing right now. They're taking a deliberate view that the way they do business, it can't just be about feeding, sleeping and settling anymore. We need to do more than that. And that has workforce training implications. But we need to think across the whole system in terms of upskilling and retraining. And then on the other side, there are agencies that are related but don't have a particular focus on child and family services. And that's where places like Housing SA would fit. And indeed, corrections, police and courts and Centrelink. So there's a potential here across all of these agencies, and if protecting children's everyone's business, then we're going to have to work across some kind of system map like that and look for leverage points where everybody can start to do better. And that doesn't even include the community-controlled and non-government sector yet. So in South Australia, we've got at least 10 government agencies that already have a child and family-focused service provision. What are we going to do with that? Nobody knows what to do with that, and the solution to that will be local. We will have to develop this ourselves, and we can do that. So one of the challenges for people like me in the research game is if you look across the quality of the evidence we have, 50% of it's not very good. Now, I know you think everybody with a PhD must be brilliant. It ain't true. If half of the research we've got is actually not well evidence-based, then how do we start to move collaboratively toward a better evidence base? That means researchers working with folks like you to get better evidence that's generated from the ground up. So you might have heard of evidence-based practice. Well, actually what we need is practice-based evidence. We need to switch that on its head. Okay, and I've been pushing the idea of good enough evidence. We will never have the money, the resources, the time, the people to to run randomised control trials of everything we think can help families. That is not going to happen. We should reserve, they're very expensive to run, they're very hard to do. We should reserve those for when we think we've got something really special that works. So what are we going to have for good enough evidence? Well, that's going to come from data platforms like the ones we hold, where we can see people who don't get a program and we can see people who do. And there are these things called quasi-experimental evaluations, where we create a comparison group. The biggest problem you have in figuring out what works is, who do you compare to? Because you only see the people who touch your programs, and you do a pre and post. But what about the comparison group? When we get a comparison group, then we're starting to build higher quality evidence. And so the advantage of what we have in South Australia is we've got the comparison groups. They're sitting there. We just have to find a group that looks like the families and the children that you support. We find another group who looks just like them, but was not involved in your program, and we've got an outcome that we care about that's being measured. Then we're actually in a pretty good space scientifically to compare those outcomes. And that's what I mean by good enough evidence. By all means, let's run the trials when we can, but we'll never be able to do all of those. So all of our work is around trying to contribute to the intergenerational, breaking the links between intergenerational disadvantage and getting those kids who are born into these disadvantaged circumstances, and there's way too many of them, just trying to tip them up onto better tracks.
So we really need to understand, how do people get into positions of profound disadvantage and why do they get stuck there? And so quite a bit of my talk is going to come out of that. And as I said, that really highlights the role for family, and it comes out of this sort of intergenerational transmission idea of disadvantage, which really highlights the role of the first 1,000 days. And I think when we think first 1,000 days, it's not just infant, it's also parent and soon-to-be parents, and they need to be part of the picture. Part of what we're saying is we actually know where to find vulnerable people. They are sort of banging up against the system wherever you look, and they're in the data set. So we actually know where to find people. So we're pretty good at the case finding. We're not so good at the helping. And I think you people are sort of some of the front line in doing that, but we clearly need to be doing better. This work is published. But it does mean that for both your Aboriginal and non-Aboriginal children, having a mother involved in the sort of who's been incarcerated, the risks to them are huge. A high percentage have really insecure housing situations. So, for instance, only 15% of these women who are pregnant are actually just living with their partner. Most of them are living with assorted adults, sometimes mothers, sometimes not. And one of the things that the home visitors say is that they can provide all the information and advice and support, but if a mother has no control over her income, no control over whether a child's got somewhere safe to sleep, they can't control people coming and going in the house, whether there's going to be food there when they come home, it's extraordinarily difficult for them to actually implement the knowledge they're gaining. So I think it's sort of really part of what we've been doing with this work is trying to get a handle of the sort of complexity and the vulnerability and the level of disadvantage we're talking about. And I think for a lot of people who are setting policies really don't comprehend the extent of complexity in people's lives. The evidence over the last few decades has been growing that adversity doesn't come from nowhere. It's sort of linked to trauma. And what we sort of had the idea is it's not just about the psychological distress. We need to think about the adversities they're facing. And we found there's actually a large group who have this combination of high levels of psychological distress and adversity happening. And we said, look, all of those groups need to have access to high-level, highly skilled mental health expertise, but it needs to be linked with really comprehensive family support services. That either way, there's no point having one without the other, because we actually need to be able to address all the things that are going on with this person. If you have a young teenager who's self-harming, but you don't actually look at what's going on in the household. Relational trauma is also another way of thinking about child maltreatment. Effectively, it disturbs the relationship between parent and child. So it affects impulse control, cognitive functioning, ability to focus and plan, compassion. Often people go into a space of seeing people as object rather than subject. Dominant, submissive, hierarchical way of being in the world, hypervigilance, poorly developed sense of self and lack of agency, shame-based and easily triggered. And what's quite interesting when you think about those sorts of effects, it's then very difficult, and we do a lot of blaming. If you think of sort of the domestic violence sort of dialogue, it's about, well, you know, just say no to anger or just say no to violence, and it's actually ignoring why someone is in that place in the first place. And it's a bit, if people's brains are damaged, then that actually reduces their capacity to have that level of control. So I think this is really critical because this then feeds into the sorts of services that are actually needed on the ground to really help people. So abuse and neglect, parental mental illness, substance use, etc. in the household, that has negative consequences for the child in terms of cognitive, emotional, behavioural, sort of often antisocial behaviours, and this then affects their often performance at school, their engagement at school. Often they end up getting bullied or being bullies themselves. Often they then go to self-medication with drugs and alcohols, often from quite early, which further disturbs brain development. So you end up with this sort of cascading of adversity and issues, and that's why you have some people that seem to accumulate adversity, further reducing their life chance, which is another reason why we need to try to get in early before we've had that opportunity for adversities to cascade and accumulate. And why is sort of relational trauma so toxic? So this is the sort of child abuse and neglect. Partly it's happening very early in life, and as I said, often pretty much certainly from in utero. We know by the time the child's born, I mean, it's already 9 months from conception. You know, they're not in some sort of soundproof box. I mean, they're actually getting sort of hormones from the mother. It's at some point they can sort of get the sense of stress or violence or noise that's going on in the household. The brain is developing early. Relationship patterning is happening. What I mean by that, and some of the work that we've done, identified that for, or really postulated, that for children in a maltreating family setting, what happens is that, and going to drawing on evolutionary theory and animal models, that essentially what you have is something like an animal troop where there's threat from within. So if you think of sort of a chimpanzee troop where you have the sort of superior animal, everybody else in that troop is referential and very hypervigilant around that superior animal. You get very narrow focused of attention, and it's very difficult for anybody in that situation to have sense of agency and self, because their whole sense of being is tied up with the superior animal. And essentially we're sort of arguing that this model actually applies in families where you have child abuse and neglect, that you get these very enmeshed relationship between often mother and child, parent and child. And so that sort of relationship, that way of understanding what relationship looks like, which is very hypervigilant, very threat-based, becomes the sort of their understanding of relationship. So even when somebody moves outside of that and in other contexts, they're often looking for that threat, so they get quite easily triggered, can become quite defensive. Somebody doesn't even realise they've triggered somebody because that's sort of the frame, that's the way they understand relationship. So I think these things are quite durable, and unless we understand that, it's very easy for people to get triggered and things to sort of go into meltdown. This sort of whole concept of intergenerational transmission of trauma, and why pregnancy and that sort of neonate period is both a time of great risk, but it's also a time of great opportunity. And I think we need to sort of look at as a time of great opportunity to turn things around. And why is it so problematic? And as we said, that exposure to this sort of early childhood trauma when the brain is developing, it affects everything about that child, including the way they're likely to parent. So we're sort of getting this sort of intergenerational thing likely to set in for parents with a child maltreatment history, that they're very vulnerable when they have a child because that child can actually trigger their own trauma. So often that will disrupt their parenting. So again, it's a time when the parent with that sort of history is vulnerable. They need support so that they then don't replicate their own history with their child, obviously unintentionally. That idea I was just talking about before, that if a parent sets up this sort of child maltreatment relationship, then the child ends up with this sort of relational patterning, which is called agonic mode, which, while it's protective in that situation, is often very unhelpful when they're sort of, basically trying to operate in the wide world. And as I said, the sort of epigenetic pathway. So there's so many reasons why that perinatal period and infancy is absolutely critical. So I think we've already gone through that. And the other thing about, I suppose, what's also setting up the sort of intergenerational transmission pathway is that the very outcomes of child maltreatment for the child are exactly the same risks as a parent to become a sort of an unintentionally maltreating parent. So the sort of consequence, we end up in this sort of consequence sort of adversity risk cycle which keeps it going. And going back to the point I think in John's work that he mentioned that people with their own child maltreatment history are much more likely, or the children in the child protection system are likely to have had parents with their own child maltreatment history. If we're thinking prevention, and often the government sort of rabbits on about the need for prevention, is if in fact the pathway is intergenerational, is from highly vulnerable who then have children who will also be highly vulnerable, then it suggests your prevention is disrupting the intergenerational pathway. It's not working with people who are doing fine, who have no adversity, and stopping them sort of becoming stopping them from experiencing multiple disadvantage. It tends not to work that way. It tends to work much more across this sort of intergenerational pathway. So it has a really important implication for intervening, which is very much about helping families to get off this sort of treadmill they're on. So this is sort of where I'm going now. So the sort of issues, the things that come out of it, firstly that the infant child must be the centre of any solution, and that actually means family. The infant child doesn't come on their own, they come with families, and we need to work with families. And the other thing is, we also need to be working with, with future parents. So teenagers are really important. I mean, particularly in these vulnerable communities, they'll be parents very young. And I think the other thing is often we sort of leave dads out the picture, and we need to work out how to bring dads in as well. And particularly often boys that sort of suffer in terms of both sort of a maltreating history, but then often they don't have, say, role models or other things like the early childhood space. There's only 3% of early childhood workers are male. Primary school, we've now got fewer and fewer males. So I think we're sort of not doing very well with our boys, and we need to think of what we can do to really help them. Whatever we do, because we're dealing with traumatised people who are easily triggered and traumatised and already coming from a very shame-based space, then the challenge is to provide services which are highly compassion-based in a warm and welcoming environment. And I think that's absolutely not what a lot of services do. I think if anybody tries to sort of get themselves onto Centrelink, they'll find it a hugely disturbing exercise, let alone for someone who's sort of perhaps intellectually compromised. And it's not a very welcoming and supportive space. So I think we need welcoming environments, outreach-based, responsive. We need to be actually go out and find people, help bring them in to our service network, adequately resourced with secure funding. And this is a space that people in the room will know that Funding agreements are usually 1, 2, 3 years if you're lucky. Going out to competitive tender, not necessarily any logic why projects might be wound up, moved to someone else. This isn't a way to service our most vulnerable families with highly skilled expertise. So we need security, and we need actually adequate funding. And the other thing is we need to sort of go for a trauma-informed approach across the entire human services sector, because we know vulnerable people are bumping up against the sector every day, and it only takes 1 or 2 agencies who operate in a very judging and shaming way for people to be triggered to really sort of lose it, and the children will suffer with all this. And also for the services themselves, they need to be able to operate in a very compassionate and supportive way with their own staff. If the staff are supported, then they're more likely to be able to support families. And also families can see there is another way of behaving. There is this sort of compassion. If workers can themselves be compassionate to each other, then that modelling is really critical. And the other thing is to try to find ways to support self-other differentiation, to support agency, and not just sort of in a sense assume it's there. Because often people will take a lot to help them take that level of control and feel confident and competent in that. So we need to be looking at going early childhood centres, because they're both a welcoming space to provide opportunity early in life, and also where families can perhaps be engaged with over a period of years, because often it takes time to build up trust with people. And I think there's a lot more we can be doing in community settings. So, and the other thing in terms of, I suppose, is sort of from silos to symphonies, we're going to have to work in an interdisciplinary and cross-portfolio approach, because the families who are coming to us, they have problems which actually cross portfolios. So it's absolutely pointless coming to them with a single agency solution or single... because actually it'll fail, because people need to support it across a whole range of things to sort of, in a sense, leapfrog them up to the next level. So we need to be able to, at the same time, address their mental health, physical health, things like housing, income, education, employment. And I know that's a hard ask, but we're going to have to find a way to do that if we're going to really be able to address the sort of level of disadvantage and vulnerability we see. Where are we now allocating resources? Well, we're putting a lot of money into universal services, things like income support, tax incentives, child protection. So we're it's not really very sensible what we're doing. There's very little going to infant, child and family community mental health or family support. This is a few years old, but it won't have changed a lot. So this is actually looking at mental health payments. That big yellow block is disability support pensions. So, hey, that's where most of our money's going. The little red wedge is Headspace. Beyond blue, the little purple wedge. So we're sort of doing very little, which is actually trying to help people before they get to the sort of disability space. And I think sort of the NGO sector, I think one of the challenges there is how do we get the mental health expertise in together with the sort of the social work and other family support services, because that's not necessarily available through referrals. I think there's some really interesting options is preschool justice reinvestment, and I think there's been some comment about what can be done in terms of the youth justice area. I think that's certainly in the States there's been some very good programs. The Washington State Institute of Public Policy have published quite a lot around what can be done, and I think Washington's been very successful in reducing their incarceration rates. And we could actually be using prisons as a place of rehabilitation and therapeutic support. And the other barriers are things like evidence-based. We still need to build more evidence there, and it's not simple. There's major organisational barriers. We still, I think, have punitive community attitudes. You can see that in the domestic violence debate. We can see that in the debate of, GOM 18 orders. Children are removed from perhaps 12 months. It's very difficult for those families to get their children back. People are constructed as, whether it's domestic violence or child maltreatment is bad, not troubled, not traumatised, not challenged, not sick. And I think we need to change that conversation because I think until we actually change that conversation, we're never going to get the resources into this space. And we've got sort of power and vested interest that somehow or other manage to sell their message as well, we're talking for the community. It's like, no. And I think also in this space, how do we, even though we've got a whole aim is to engage with end user, how do we engage with infants? How do we ensure that they're actually being adequately represented? Who is talking for them? As an economist, I think there's sort of a role for economics in this space to generate the policy relevant evidence, to do more work around costs, return on investment, cost effectiveness, cost consequences, and there's a lot more we could be doing, but there's very few economists working in this space, unfortunately. And I think everybody needs to be, I suppose, jumping up and down about the need for equity, that it's an absolute disgrace, the inequity we have across every outcome measure we can think of. For those who are in the research community, we need to make sure we're doing good quality science. And in terms of the dialogue about prevention, let's shift that to preventing intergenerational transmission, not preventing low risk going to high risk, because the intergenerational is the main transmission pathway, not the low to high risk, which means really let's put the resources with the most vulnerable. And ensure, as I said, as an economist, I need to be ensuring that the economic consequences of not taking the efficient path is made clear.
I'm really thankful, grateful to be here with you today to think about these challenging issues around how we really actually move the needle on key indicators of wicked problems, how we promote the well-being of children and young people, how we strengthen families, how we strengthen communities. And as Jeff mentioned, in particular, I want to think about that in the context of Communities for Children, the tremendous national resource that's represented by the infrastructure, the national infrastructure that's been funded for years and years and years through Communities for Children. Because I got involved in this work when, as Jeff mentioned, Ross Hummel from Griffith University in Queensland he had seen a report that came out in 2014 that essentially found that, after years of this valiant effort, that Communities for Children wasn't really making the kind of impact that we hoped it would make. And so Ross Hummel had been familiar with some work that I had been involved with in the United States, where we had been successful in taking a collective impact initiative, scaling it up in many, many communities across the whole state, and we were able to actually significantly move the needle on key indicators of child well-being, measured at a population level, measured across whole communities of children, regardless of whether they had been through a specific targeted individual intervention. We were able to shift the needle on community-level population health, public health. And so Ross came over to visit us in the U.S. He told us about what was going on in Australia, and that began a long relationship between me and this research team at Griffith University, where we've just been continually thinking about, well, what makes collective impact work? What are the essential components of an effective collective impact strategy? And how can we, rather than, as Jeff said this morning, throwing out the baby with the bathwater, how can we take the significant infrastructure that's represented by Communities for Children across Australia and embed good science, good prevention science, good implementation science into that existing infrastructure and strengthen the way we actually do Communities for Children? We are currently in a significant, important period of enlightenment in this space, in this sector. We have only recently entered a period of enlightenment where the last 30 years has generated an explosion of prevention science and new knowledge about the precursors, about the causal risk and protective factors that put children on trajectories toward poor outcomes. And that new body of knowledge has really upset our centuries of thinking about how these problems happen and what would be the way to address these wicked problems. So we've just been exposed to new technology in the form of this new knowledge base. We have new ways to think about. Think about concepts like the social determinants of health, which I would rather call the social influencers of health. I'm not deterministic. But think about the complexity of the social determinants of health. Think about ideas like adverse childhood experiences, childhood trauma that has lasting lifetime physiological impact on individual children. These are new ideas that really help us better understand the complexity of the drivers of the wicked problems that we're trying to prevent and reduce, right? So faced with that new knowledge, it's time for us to step back a little bit and think about how we now need to reinvent our entire network of systems and structures and resources. We have to think about what new capacities, this new knowledge, this new innovation in our understanding, what new capacities does it mandate that we now build into public systems and communities to create enabling contexts for us to unleash the potential of this new knowledge base? So there are lots of pieces to this puzzle of the work that we're doing. And I think one of the most important things that we can do to go forward is to step back. Step back and look critically. Unpack all of these overused trite terms that have come to mean everything and so they mean nothing. But let's think about what the different pieces, what the different important key pieces of this puzzle are. So we've got collective impact. Let's unpack that and think about what does that really mean? Is it really better to work together? Or is the whole really better than the sum of its parts? Or does it just make us go to lots more meetings and work more inefficiently? Let's think about that. Let's think about how could we practice collective impact in a specific way, guided by science, guided by this new knowledge base to help it mean something rather than just words. Let's think about community voice and engagement. Again, something that we pander to all the time. We say this is a community engaged initiative. We say it's communities for children. But how often are the communities and the children actually at the table? What are we doing to build the capacities of the children and families who live in the communities we're trying to work with, work for? How often are we really, truly, authentically engaging them in this process? It's tough, it's challenging. That's the scary part. Place-based strategies. What does that mean and why does it matter? Place-based strategies. That could mean something, it could mean nothing, it could mean everything. I showed you that picture of myself in Colorado on my horse with the buffalo and whatnot. But I spent most of my professional career working in America's most violent cities as a youth gang specialist for the United States Department of Justice. And so that was the context that I worked in with young people, and that was the lens that I viewed the problems through. And now I live nearly 30 kilometers from the nearest traffic signal. So context matters, but no matter where I have been, whether it's the most violent urban cities in America or out in the middle of nowhere in a very rural agricultural part of Colorado, I can tell you that in every community in America and every community across the world, parents, communities are concerned about the same things. They're concerned about youth violence. They're concerned about drug use. They're concerned about the mental well-being of children and families. They're concerned about drug use. They're concerned about bullying and truancy and school leaving. They're concerned about smoking and drinking and cannabis use and harder drugs. Every community is concerned with trying to achieve better outcomes for children and families. And every community has some amount of these behavioral outcome problems. But I will put to you that what drives those problems is very different from one community to the next. What drives those problems is very different from one community to the next. So we can't sit in the capital, in the state capital or the country's capital, and come up with some one-size-fits-all solution and push it out to such a diversity of communities. One of the biggest challenges to effective policy making is coming up with a policy that is equally beneficial to a wide variety of very different communities. So I'm going to talk to you about, instead of a solution that is a program, a solution that's a process, a solution that is about skilling up the capacities of local communities to use the latest science and research and use good data to inform them about what the problems are in their community, what is driving those problems in their community, and what would be the best fit solutions for their community. A greater investment in prevention coupled with a greater investment in capacity building infrastructure can maximize the future potential of Australia's population health, its workforce, and its economy. We can do this. This is something that we can do. We can do it because I've seen it done. So the earlier we start, the less history we'll have to unpack to change a child's trajectory, right? So as I mentioned that we need to start from the place that prevention works. All of these wicked problems have been prevented in randomized controlled trials. We have evidence-based approaches for every one of these wicked problems that vex us. And I think the important thing to take away from that is that prevention, changing children's life course trajectories, is not something that we just passionately, philosophically believe in. It's science. It's empirically proven. And there's an important difference between those things. We're no longer working on faith. We're working on science. And once we empirically prove that we can prevent these wicked problems, we have a moral and ethical responsibility to do that. We can't just say, well, bad things happen all the time. Let's just sit around and wait for the children to sort themselves into our system silos, and then we'll try to clean up the mess. We have a moral and ethical responsibility to take what has been proven to work and do as much of it as humanly possible, to narrow the funnel, to reduce the numbers of children that flow into our systems. If we're struggling with something that's at an epidemic proportion, like child abuse and neglect or heart disease or lung cancer, if we're struggling with a public health epidemic, we first start by doing epidemiological research. We study the population that has that problem, and we look for things that they have in common. We look for characteristics that population shares. And then we look for characteristics that population shares that the rest of the population that doesn't have that problem don't seem to share. And those become our known risk factors, right? Those are identified as things that statistically predispose us to some poor outcome. So if you smoke, what does that statistically predispose you to? Yell them out. Emphysema. What else? Smoking. Why don't we smoke? Why do we encourage populations not to smoke? I'm between you and lunch. Yell them out. Heart disease, lung cancer, emphysema. There's a whole host. We know factually that there's a whole host of poor health outcomes that you are at greater risk for if you regularly smoke. And that's why smoking rates have gone way, way down. We studied that. We identified smoking as a risk factor not for one thing, but for a whole host of poor outcomes. We educated the public about that, and now the public is engaged in reducing and preventing those many poor health outcomes, and the rates have gone way down. We can say the same thing about heart disease, right? We know that if you smoke, you're at higher rate for cardiovascular disease. We know also, though, that if you have a poor diet, if you have a sedentary lifestyle and you don't exercise, if you have genetic predisposition in your family, all of those things individually and collectively put us at statistically greater risk for cardiovascular disease. So those are risk factors. So we've taken that same thinking and applied it to things like youth crime, youth drug use, child well-being, school failure and leaving, teen pregnancy. We've studied the populations of young people who have these issues, and we've identified characteristics that they share in common. And those have become the known list of risk factors that we're trying to target in this work. So we can take that same idea and apply it to what communities do in the name of collective impact and prevention, community-focused, place-based prevention. We bring the stakeholders together, bring all the stakeholders together in a community. We create a community diagnostic risk profile that's specific to that given community that says, here are all the known risk and protective factors that are associated with these wicked problems we're trying to prevent and reduce. Here's how much of those risk and protective factors exist in this particular community. So now we have a community-specific diagnostic profile. Then we use that diagnostic profile to select priorities and strategies that match that profile. And then we implement them, and then we evaluate them. This sounds like complete common sense, right? This sounds so obvious. Does it reflect business as usual? Ask yourselves that. I can go into any community and say, make me a list of all the programs and services you currently have in place that are being offered to children and families in the name of improving their outcomes. For each one of these, tell me how it ended up here in the community. Did it end up here in the community through this kind of data-informed diagnostic strategic prevention planning process? I argue in most cases, no. Some have. Some programs that are currently being delivered in communities were carefully selected based on a community's specific diagnostic risk profile. In most cases, not. So why are they there? How do we know that this is the right medicine for the right illness? So we did this in Pennsylvania. We applied this approach in 128 communities across the state of Pennsylvania. We created these collective impact coalitions. We used a model that followed that process that I just described. In every community, we helped them gather data. Youth self-report data. Youth self-report, again, think about what John Lynch said this morning about the importance of not relying solely on systems data. Because systems tell stories about how systems are responding to problems. That may or may not be a story about the lived experience of those people. If you want the story of the lived experience of people, if you really want to know what the risk and protective factors are in a given community, you go to the people themselves. You ask them to tell you, to self-report on their lived experience. So we primarily use a youth self-report survey that collects data on these known risk and protective factors. And then for each community, we generate a data profile that is the catalyst for a community-led discussion. It's maybe facilitated by professionals who are skilled in collective impact and community organization, community mobilizing, but it's a locally driven conversation about what does this data from our children that our children have just given to us, what does this data mean to us, and what will it say about what our collective impact priorities are? The collective impact priorities, so in this case, this community has used this data. They've acknowledged that the risk happens in different ecological domains. So we encourage them to pick a priority from across multiple domains of the ecology. We don't want to just be working in the schools. We don't want to just be working with the families. We don't want to just be working with communities. We want to make sure we're hitting all of those spaces, so across the ecology and across important developmental milestones. So there are specific developmental high-risk periods where we want to make sure that we've got something in place in all of those important high-risk periods. So this community said, okay, well, based on this, if this is our data, we're going to focus on low neighborhood attachment, parental attitudes towards alcohol, tobacco, and other drugs, academic difficulty, and low school commitment. Now they've narrowed down their long list of all the possible things that science says might be driving the problem in their community, and now they've identified 4 very specific things that the data from young people says are most likely driving the problems for most of the kids in that community. Does that make sense so far? Now, the importance of this, there are several important aspects of communities getting to this place. One is they've gone from trying to address everything, which will never have enough time or energy or resources to do, and narrowed it down to 4 very specific things. These 4 very specific things are risk factors for multiple behavioral outcomes. So they're of interest to multiple siloed systems. Does that make sense? Just like tackling smoking instead of tackling cardiovascular disease. You tackle cardiovascular disease or you tackle lung cancer by tackling smoking, the underlying risk factor. And at the same time, you might tick multiple boxes, right? Now, I want to stress that these 4 things that the collective impact group has determined are their priorities. That does not mean that everybody that's part of the collective impact group, that all the NGOs and service providers are being asked to abandon their own priorities, to stop doing whatever they've been doing, and now take a hard pivot and only do these things. These 4 priorities don't become everything the community does. They become the very small number of things that the community gangs up on. These are the 4 things we're all going to do together. Everybody else still gets to maintain their territory. Everybody gets to continue doing what they've been doing. Now, so an individual agency or service provider that's part of this collective impact coalition can say, okay, what have we always been doing? What's our current array of programs and services that we're currently delivering? We never had this data before, so we never knew that these were important priorities for our community. Is there any way we can take any of the programs and services that we're already delivering and maybe tailor them a little bit to be more specifically directed to one or more of these risk factors? This is the collective impact part of collective impact, right? I use the metaphor of a magnifying glass. Now I'm gonna date myself again. Do people remember playing with magnifying glasses and shining the sun through magnifying glasses and trying to set grass on fire? Remember that? Right? So when you do that, when you can start a fire on the grass with a magnifying glass, you're not adding any resource material to that. You're taking the same number of individual rays of sunshine that were already falling on the grass and not starting a fire because they were all spread out and diluted. Now with the magnifying glass, with the collective impact glass, with this lens that's informed by data, you take that same number of resources and you focus a portion of them very narrowly on a narrowly defined target. And now you can start a fire. And now you can move the needle on these wicked problems by addressing their underlying risk factors. Does that make sense? So we did this, like I said, we did this in these 128 communities throughout the state, guided them through this process, and as a result, we went from this being our footprint of evidence-based strategies that were being implemented when we started to this. We literally saturated the state with evidence-based programs, but we saturated the state with evidence-based programs that were carefully selected by communities because they met a need, a very specific need that the community had identified using local data. And that's different than we saturated the state with evidence-based programs because we mandated that they spend 30% of their money on things that are on a list. Right? That's different. So we have, part of the reason I think policymakers want to mandate a minimum percentage of things that be spent on evidence-based programs is because they understand that evidence-based programs can be valuable. But if communities don't have the infrastructure and the capacity to do this good local diagnostic needs assessment, what other option is there? How could communities pick something off the list? Well, it's on the list, we'll get money for it, let's pick it. Right? Then it makes no sense. That's a dogmatic approach to evidence-based strategy. Now, when we measured whether any of this was making a difference across these 128 communities, so I mentioned that the communities create this diagnostic risk profile based on a youth self-report survey. The good news for us from a research standpoint was that this youth self-report risk assessment survey that these kids completed in these 128 communities was actually implemented in all the schools in the state. So every community was collecting this same data, but only these 128 communities were using the data to do data-informed strategic prevention planning and a collective impact framework. That meant that we had 400 other or 380 other schools, communities, that had similar data but weren't doing anything with it. That created a great natural experiment, what John Lynch referred to this morning as a quasi-experimental design. We've got a comparison group here. And so when we followed the kids that lived in these 128 communities and we compared their risk and protective factor data and their prevalence rates of problem behaviors over a 5-year period and compared it to all the kids in the other communities that weren't using the data in this way to do data-informed strategic prevention planning in a collective impact framework, we found that these kids in these collective impact communities had significantly lower rates, both practically significant and statistically significant difference in terms of lower rates of delinquency. And I forgot to mention, this whole initiative was rolled out as a youth crime prevention initiative. This was rolled out across the state to try to address the narrowly defined problem of youth crime, juvenile delinquency, kids ending up in the youth court system, right? So we ticked that box. We did that thing. It met its primary goal. But when we were doing this, we never talked about youth crime. We talked about risk and protective factors. Because guess what? The same things that put children at risk for youth crime and delinquency put kids at risk for school leaving and for youth drug use and for teen pregnancy and for depression and anxiety. It's a shared, common, universal group of risk and protective factors, right? So instead of going into this saying, we want to reduce youth crime, let's focus on youth crime, let's focus on when youth crime is happening and be narrow in our focus. Instead, we said, let's look upstream at where this youth crime might be coming from and address those underlying causative mechanisms. So we ticked that box on youth crime, but guess what? We also found that these kids said they were much less influenced by negative peer groups. In fact, we did, interestingly, we did a social network analysis. This was kind of a side project. We did a social network analysis. And I don't know if you've seen social network maps. Basically, we asked kids to tell us who influences them in their peer group among their school grade or classroom. And they identified the initials of the kids' names or whatever. And we can create a map, a pictorial map of the network of peer influence. And what we found was at the beginning of this, at the center of the network of peer influence were kids who were mostly antisocial. They had antisocial ideas and attitudes and intentions. And later on, when we remapped these social networks, we found that the networks had actually changed. The peer group networks had changed to where the antisocial kids were now out on the fringes of the peer networks. They were no longer the primary influencers of the peer group, and the kids that had moved to the center of the peer social networks were actually pro-social, more pro-social. So that might be part of what's explaining this reduction in negative peer influence. These kids in these collective impact communities told us that they were much more engaged in school. They had higher, statistically and significantly higher levels of school engagement. They were finding schools a more enjoyable place to be. They were recognizing the value of being in school. And they achieved 33%, now 33% comparative across a 33 comparative difference between the two groups. 33% better academic performance. 33% better school grades. 33% better school grades. This is a youth crime prevention initiative. What business does it have impacting school engagement and school grades? Tell me. Who knows? Why would a youth crime prevention initiative impact school engagement and school performance? Yes, because we're focusing on risk and protective factors. And the same risk and protective factors that predispose kids to youth crime predispose kids and more kids, and probably sooner, for school engagement and academic achievement. Right? Makes sense. Now the school, when we started this collective impact initiative, it was kind of tough to get the schools engaged in this process because they had heard that it was a youth crime prevention initiative. And they're like, well, that's not our business. That's not our silo. That's somebody else's silo. When this data came out, now all of a sudden the schools are encouraging other schools in other communities to get engaged in this process because they can say, now this matters to our silo too. So this is a boundary spanning approach. This is a silo spanning approach because the underlying risk and protective factors, they're not slaves to anybody's silo, right? So again, this is a collective impact process through risk-focused, place-based, because it's specific to place. Each community has their own profile. Each community makes their own decisions about what that profile means in terms of what's driving the problems, what problems they care about, what their priorities are. The community selects the priorities, and then they choose programs and strategies that they think meet those priorities. Get to wrapping things up. This is the formula then. I would say that if I took what we did in Pennsylvania that demonstrated population level improvement, significant statistically and practically improvement on key indicators of child well-being, and I tried to unpack what were the important aspects of that led to that aren't always reflected in business as usual in collective impact initiatives. I would say it is community mobilization with technical assistance. We have short-shrifted the whole idea of community mobilization, of collective impact. We act like this is so easy. We tell communities to coordinate, create a symphony. That's hard stuff. I'll assume that most of you live in a neighborhood, on a street with lots of neighbors. What if I said to you, I will buy everybody in your neighborhood dinner and a movie if you can go home after work tonight and in 2 hours bring all those people together and get them all to agree on what restaurant they're going to and what movie they're going to see? I think my money's safe. That's hard. That's hard negotiation. And think about how that's, jokingly I made that, but think about how hard it is to do the very thing that we're trying to do here. Part of the work that we're doing at Griffith University is creating a new profession called collective impact facilitators that recognizes how difficult this is and what skill set is required. I mean, this should be a recognized profession with specific professional training, workforce development that produces people with the necessary skills to do this kind of work. Systems coordination, we have to reimagine our silos. Data-informed surveillance and diagnosis. Do we even have that capacity? Can we do better at that piece of it? That's a place to start. Evidence-based strategies carefully chosen and applied with fidelity and sustain. So that becomes the formula. So, we need infrastructure support across all of these things. These are new ways of doing business. If we want to do communities for children and have it make a difference, we need to step back and critically reassess what capacities don't currently exist in the infrastructure of C4C that we could build up those capacities instead of, and I hope you're not mad at me. I hope I don't get run out of the room for this. Instead of investing more and more and more money to do the same things that we've been doing and expect them to turn out differently, I would say that it's a better investment to take some of those resources and invest them in this kind of capacity building, these specific kinds of capacity building that allow us to really do collective impact effectively.